Data is the key to the future. And you have a fantastic opportunity. And so I'm going to leave you with what I call the 3 Bs. I want you to be ready. I want you to be ready for what comes after 2015. Your question. What happens after 2015? The answer is, I don't know, but prepare for the worst, because the best might happen. But you need to be thinking about how you run these services with pretty close to flatline funding, because I don't think there's going to be a shitload of money coming in. I really don't. Unless they change their mind on tax policy, and let's hope they do. You need to be ready. I think you've got to be open. You've got to be open to innovation, change, and new ideas. I'm going to stick my neck out and I say I think the GPs are going to be the hardest people to change on the island, because they are all partners, they all own their own businesses, and all of them have spent a lot of time working in that kind of model. Changing that model for them is going to be very difficult. And changing the model to help them do it is going to be very difficult. They've got to see a future. You can't expect people to buy into the future unless they can see what it looks like. People love change if they think they're in charge. Very simple. And they can't think they're in charge unless they can see what the future looks like. You need to be able to paint that picture. And lastly, my 3rd B is I want you to bring yourself to work. I want you to bring the expectation of the kind of technology that you have in your normal lives. I want you to bring that to work. You know, you go shopping and you check out yourself. Don't you do your own self-checkout? Who likes a self-checkout? Yeah, who doesn't like the self-checkout? Who hasn't got a clue what I'm talking about? Okay, fine. Yeah, you're inside there's a big woman called Brenda with a hairy mole, isn't there? And you're trying to do something, and she's an unexpected item in the bagging area. You're in Tesco's, 50,000 things are on the shelves in Tesco's. What could be unexpected? How does that work? Oh, you try and buy a bottle of Pinot Grigio. Authorization required, and you stand there clutching your bottle of wine like you've escaped from rehab. And then a child comes and authorizes it. Bring your expectations to work. You know, I mean, if someone has diabetes, I'm sorry they have diabetes, but we love bomb them in the NHS. We surround them with services. I think we've got to get to the time where we say, you've got diabetes, and I'm really sorry you've got diabetes, but it's your diabetes. We'll show you how to look after it, but here's an algorithm, and here's a thing, an app for your phone, and this is how you do it. And, you know, that kind of remote technology, I think, you know, unless we start using that type of technology, we haven't got a prayer. So that's really all I've got to say. I just want to say that I'm very pleased to be back on the island. I do come here quite often over the weekends, and we come down to stay at Rothsay House, that's the B&B run by Mad Margaret. It's a fantastic place to stay, because I fairly frequent visit. But I've come and seen the services, and what I've seen this morning is, I think it's stunning. You've done your streets ahead of the game in other places I've been. So congratulations on that. Please take advantage of the 5-year forward view. Please be a vanguard. Please be open-minded. And I think, you know, we'll all be here in a year's time and things could be very different. So thank you very much for listening.
I've got 7 minutes for questions, so I'm going to finish it at 2 o'clock. So let's get some of your points and questions in, please. If you wouldn't mind being brief, so we might get a few more in, say who you are, Martin.
Hi, Martin Robinson from the Trust. What do you think about commissioning? Commissioning costs, say, 13 billion, something of that nature. Do you think it's good value, or do you think actually we should invest more or less?
I think overall commissioning will fizzle out. I think that, first of all, if you're commissioning for competition, there isn't going to be any. If you look at what's happened in the private sector, Circle have pulled out of Hinchinbrook because they can't make money. Serco have pulled out because they can't make money. Bupa have pulled out of their musculoskeletal joint offering because they can't make money. The tariff is too tight. You can, if you're in business, you only do it because you can make a margin, and you can't make a margin in health at the moment. That isn't to say that things won't change. But even if you could do 5% efficiency gain in the first year, which I don't think you could, I don't think it's worth doing. As far as commissioning is concerned, generally, I think it will just fizzle out. I think we're going to get more to vertically integrated care. I'm a big fan of population-based capitated budgets. which on the island it's perfect for you to do. And I think commissioning will give way to a more of an operational allocations model, where you effectively commission, I don't want to use that word, but you commission for outcomes. Because at the moment we commission for inputs. We say, here's a contract and you've got to do this on a Monday, that on a Tuesday and this on a Wednesday. But we never say you've got to do this on Monday, that on a Wednesday, this on a Tuesday, and we want this outcome on a Friday. We don't commission for outcomes because we just can't do it. We're just not good enough at it. The outcomes are too difficult to define. So I think it's probably gone full circle, and I'm sorry to say this. I know I can't stand here either. I don't know where to stand. But I think commissioning will fizzle out, and I think you should be in the vanguard of doing that, because effectively you do have a population-based capitated budget already, and you could do so much more with it if you ignore the boundaries and shared that budget across health and social care. That's the big thing for me. We've got to get rid of this boundary between health and social care.
Ali at the back.
Thanks very much. Well done on the excellent presentation. This is Ali Albarani. I'm consultant chemical pathologist.
A what?
Consultant chemical pathologist.
Good God.
My good patient,
What have you got wrong with you? Shit, I don't think I want to meet you again.
my good patient called me the good chemical Ali.
You know what happened to him.
Well, I mean, my question is, where do you see the future of integrating the clinician with managers?
Clinicians and managers. I would beg more clinicians to get into management. And I'm not being disrespectful to managers, because I think we've got some of the best managers in Britain working in the health service. They're highly qualified, very focused, and bring a strong sense of vocation to their work. But if you can get clinicians in management, it is so much better. And if you look at some of the big American health models, not everything that's done in America is bad. And if you look at some of the big hospitals, they're run mainly by clinicians. And so I would encourage more clinicians to get into management.
Okay, thank you. Karen?
No, it was only picking up on Martin's point. It's certainly not sitting. I'm a clinician and I'm in the CCG. My focus is very much quality services. It's not necessarily standing here defending commissioning, because we once had a model of integration on the
Yes, you did. You were strict. PCT. Your PCT was terrific.
And the sad thing for me was the duplication of effort.
Yes.
Because as soon as we separated, we all had to start creating double teams.
Yeah.
And yet, many of us in commissioning would actually value that going back to that model, because we have skill set that we can bring and share with the trust rather than sitting out there. So I mean, I don't know how my commissioning colleagues will feel about that, but certainly from a clinician's point of view, that seems to be...
Well, I think if they've never seen it, they might think you describe it a bit better. I mean, your PCT and your world-class commissioning scores were some of the best in the country. You did very well with that, and then it was all destroyed. The reason we had that split, I mean, it's worth just perhaps hovering over that point for a moment. The reason we had the purchase of provider split was the European rules. Because we had a semi-market at that time, and we were going out to tender, the European market said you can't provide services and be the tender. So we tried to put a Chinese wall down the middle. Virginia Bottomley was around at the time. She talked about the purchase of provider split and all the rest of it. We had to put more rigour in it and divide it and make it completely separate. And that's when Mark Bricknell came up with the idea of the world-class commissioning schools. I mean, those days are behind us. The great thing about change is to respect the past, to bring the best of it into the future. And if we can get into a population-based capitated model, I mean, bringing the best of what you learn in the PCT into the future, I think would be terrific. We have a lot of knowledge and a lot of skills left. I mean, a lot have gone, because 40,000 managers have gone. Mainly they're the senior managers who've got a decent payoff, and why shouldn't they? But we lost a lot of expertise. But I agree with you. I think there was a lot to be said for that brief period.
Oliver?
Yes, Oliver.
Good, I'm one of the associate medical directors here. In your blog, you write a lot about regulation or over-regulation or various regulators, sort of where we spend money quite significant numbers. An educated guess in the future where that might lead to more or less?
Yes. Look, I mean, don't start me on about the CQC. Bunch of flat earthers, aren't they? Just ridiculous. Look, if you read Edwards Deming, who's the father of modern management gurus, he said in 1969 that you can't inspect quality into services. And he was right then, and everybody who knows anything about management will tell you that inspection is not the way to do it. Total quality management is the way to do it. You were inspected here, you had 80 people turn up, £1,000 a day each, that's 80,000 quid. They were here for 3 days, that's 3 8 to 24, that's £250,000 quid, plus on cost and back office costs. They spent 300,000 inspecting you and telling you you didn't have enough nurses. Well, I could have done that. I could have done it for half the price. I'd have done it for a quarter of the price. I'll do it now for nothing. You don't have enough nurses, but there's only 147,000 people live here. How many of them are going to be nurses, for Christ's sake? You've got a problem. You've been in the Far East, you're trying to recruit, you're busting the gut, you're doing everything you can. We know you don't have enough nurses. What is the point of marking you down for that? Because if anybody wants to work here, they see CQC, oh, needs improvement. Shit, I'll go and work somewhere else. It's self-defeating. It's madness. Will it survive after the election? The difficulty is it's a Labour invention. So if Labour get in, I'm not so sure. My guess is that even the boneheads in the Department of Health are starting to realise that the cost of this is ludicrous. And there's no point in running around the NHS saying, there's not enough nurses. We know. There's not enough nurses because back in the early days of Foundation Trust, people understated their staffing requirements in order to make their budgets balance, and because they did that, the education people didn't put enough nurses through the system, so now we're reaping the benefits of that past. And we're trying to catch up, and it's just not going to work. We're going to have to go back to the enrolled nurses. We'll train healthcare assistants to be enrolled nurses.
Okay, one last question. I know you've been trying to get in.
There's a
Yes.
lady here.
Lady.
I can't see. Where am I looking?
Yeah, just here. Just waving your hand.
Oh yeah, hi.
Hi. I was just wondering, we haven't sort of discussed on demand, so the actual users of the service, which
Yeah.
is all of us at one stage of our lives, in our lives, but or many stages. So, do you have any sort of good suggestions or visions about our strategies to that? I know that you can generally say health promotion and education.
No, I'm in the interest of time, I get the question, so can I press on? Because I know we've got to be gone. Look, I agree with you. I mean, it's madness trying to deal with flow when you don't deal with demand, which is what we're trying to do. We've got to go upstream and deal with demand. Public Health England, I think, is a disastrous organisation. It's too big. It does everything from Porton down, Ebola, and stuff on supermarkets, Thomas McEwen, who's a famous public health doctor, wrote in 1969, he said, governments have done everything they can do about public health. We've got adult literacy, clean water, and childhood immunisation. Those are the three things. He went on to say the rest is the extent to which governments are prepared to interfere in the lives of ordinary people. He talked about the nanny state. And it's true, the law changes behaviour. Right. Prove it? Okay. Crash helmets on motorbikes, seatbelts in cars, smoking in the workplace, health and safety legislation. It's the law that changes our behaviour. What law do you have about, for example, obesity? What do you do about obesity? What law could you have? You could have scales by the bus stop, so you got the scale, bus driver comes on and says, no, you're too fat, you've got to walk. Could you do that? I don't know. I mean, could you have a law that says every chip shop could only have an 18-inch door? I don't know what law you can have. We are in a very difficult position because most of it's lifestyle related. I mean, I think you can do things with organisations and companies. For example, you could say, okay, let's have a competition on the island. Let's see which company can lose weight. So everybody in an organisation is weighed on a certain day, and we say this company weighs, I don't know, 10 stone. 3 months later, we come back and they enter charity, whatever, come back, weigh them again, and they say, this company weighs 8 stone, well done. You get a gold star for public health or what have you. You can do that kind of thing, and it's simple to do, and you can do it on the island, you've got a captive press, captive radio station. If you were innovative, you can do that kind of stuff. But I think we are a generation away from public health in terms of how people lead their lives, and that we go back to the school playground to do that, because all change really starts in the schools with our kids. As far as the use of the services is concerned, I think we've just got to keep hammering away at people to tell them, is it an emergency or isn't it? And I tell you what I'd really do, and I don't think I'm going to make any friends for doing this, but we've got out-of-hours services, in-hours services, walk-in services, walk-out services, services, 911. I'd scrap it all. and I give the money to the hospital and say, you do it. Because people know where the hospital is. It's got a nice car park, it's there 24/7. What's a minor injury? I don't know where a minor injury is. To me, it's a bloody disaster, whatever it is. So instead of having 4 or 5 ways of dealing with it, with 4 or 5 management structures and 4 or 5 back office costs and 4 or 5 overheads, strip the cash out, give it to the hospital, and we'll sort it out. Not a very good answer, is it?
Okay, that's lovely. Thank you. What a great way to finish as well. Could you please thank our speaker today?